e-health projects that are being implemented in Kenya using the mobile health, but these were mostly on educational programs, making sure patients are adhering to their treatment, but they are not evaluated. And there were very few projects that are implemented in marginalized areas and least urbanized counties where the healthcare needs are more. And we saw this from our previous 2 presentations. This was another one, a scoping review about sub-Saharan Africa, which also mentions that there is limited research on the availability and use of mHealth. And the authors are recommending more primary studies focusing on the use of mHealth by healthcare workers. So the benefits and challenges are not unique to Africa. These are like global challenges that are there. And we know the benefits that it enhances access to care, allows patients to receive timely, appropriate, no need for travel, improve symptom management, patient satisfaction, aligning to patient-centered, and reduces also cost. And challenges are technological barriers, of course, incorporation into the existing systems, and varying digital literacy among patients. Now, coming to what we have done. So this is our vision, trying to establish a hub-and-spoke model of a palliative care service delivery, where you are connecting home-based care all the way to a level 5, level 6 facility. And where at the home-based care level, we work with the community health promoters, allow them for phone consultations with patients, and also what we do, we implement telehospice. So we have piloted this model, we have been piloting this model, and telehealth is actually one of the things that we have tried in this model. And then level 2 and 3, where you have mostly the nursing officers and the clinical officers who become now the participant for virtual tele-mentoring. And then we have a level 4, which becomes a champion level, where you can have phone consultations for community health promoters, and there are also like participants for a telementoring educational program. And the level 5, 6 is where you have phone consultations for the providers and CME provider, and a provider who is now coordinating the CME and Project ECHO, amongst other things that they do. So this is one of the studies that we published regarding telehospice for cancer patients discharged from a tertiary care hospital in Western Kenya. So the general questions you are asking here is whether these hospice eligible patients, would they accept phone monitoring of symptoms after hospital discharge. We give them, let's say, a comfort pack that is preemptive provision of medications, and would they utilize those medicines, and what percentage of participants were readmitted to an inpatient facility. So this was a pilot study that we did at MTRH, and our enrollment goal was 30 participants. So the study design goes, we are enrolling, so there's a criteria, patients who must have be within a performance scale of between 30 and 60, above 18, with a diagnosis of cancer, who is on morphine and not eligible for chemo or radiotherapy, and being discharged for home hospice care. So they have to meet the inclusion criteria. Then after that, we are providing them some education, giving them 100 shillings of airtime, and providing them with a comfort pack. This is like medicines that they would use at the end of life. And the medicines would include paracetamol, and of course they had morphine, so in addition of paracetamol, loperamide, bisacodyl, promethazine, metoclopramide. There are around 6 medicines. The study period was 8, so we are doing weekly follow-ups with these patients, and we are monitoring the use of 24-hour hotline. So this was leveraged on the 24-hour hotline service that we have for the palliative care service that we have, which is manned by the MTRH palliative care team. So it was to use, and then we are looking at the pill counts at the 4 and 8 weeks, and what was the reason for them going off study. So we are looking at data collection was the frequency of weekly call, that is participation, use of comfort packs, medications, and reason for off study. So what we found at the end of 8 weeks follow-up period, that 8 patients were still alive, 10 had died at home, and 12 were admitted at a facility. And patients with high symptom burden, they were willing to participate. So we had 100% participation actually on this telehospice program. So patients would talk to us on the phone. The pain ratings did decrease from the initial assessment, but still remained moderately high. Other symptoms were relatively well controlled, and worry was still like moderately high, but patients were able to share the feelings with the family, and families felt confident in providing care and were receiving the information they required. And medications that were given, the comfort pack medications that we gave them, they were increasingly used over time. So how we concluded was that telehospice was something we found out that was feasible, and may provide an interim solution to managing end-of-life patients who lack access to home hospice care. This was another activity that we did. This was going out to the community, where we were training community health promoters, giving them the right tools to assess, provide care, and care algorithms for home-based care. And we followed them up for a period of 4 weeks. Actually, it was for a month, but we reported on the activities that we saw in the period of first 4 weeks. And we realized that it was like actually 2/3 of the participants, I mean for the CHPs, were teleconsulted by the patients more than 6 times in that 4 weeks. And we had average teleconsultations also with the primary care units. So we are using the palliative care units from their catchment hospitals, who are training the community health promoters to try and create that link between the community health promoters with the palliative care unit in a level 4 hospital. So through that, and then there was also sharing of mobile numbers. So we realized that even more than like 2/3 were teleconsulting. So we are also having this activity which we call the Project Echo, trying to promote primary palliative care using the Project Echo. So for those, I don't know if you have heard of Project Echo, but it's ECHO stands for Extension of Community Health Outcomes. It's a virtual platform where experts come in, and they have participants who join in. And it's more of an educational program where the participants join in from rural or remote facilities. They present cases, and you have an expert who is providing guidance on those cases. And at the end of the session, there is a didactic presentation on a topic which like immediately impacts patients. So what we realized, we have been running this ECHO for the past 3 years. Right now, we are in our 4th year, and we do these feedback surveys, and we realize that the number of participants actually has been increasing over the years, and right now we are at 623 participants. We have not analyzed data of this year, but what we find that this has been very helpful. So if you look at what I've had, put in black there, the discussions of the presented cases, like more than 80% of the participants feel that these sessions are improving their knowledge and skills. Approximately 90% feel that they've improved their professional confidence, and also like approximately 80% feel that this participation in Project ECHO has reduced their professional isolation. And approximately also 90% feel that in the future they are likely to use this new information when treating a patient. On average, the participants attended at least 3, each participant attended at least 3 sessions. Some of the things that we learned from this Project ECHO was that besides the ECHO sessions, there are also the WhatsApp groups that participants were using, and that led to improved knowledge and confidence, decreased professional isolation, because they're able to connect with experts through those groups and that platform, and which was giving them that confidence and reducing their professional isolations. But we also realize that this probably is putting a burden on the limited number of specialists that we have. So as much as we are trying to establish and develop primary palliative care, they also need to develop the specialist level services. So to conclude, I would say that yes, use of telehealth is feasible. We can do that. And there is an interest and willingness to use the various aspects of telehealth, and can be used at every care of delivery. And we can begin by using just mobile health, And if you see, like in 2022, 94% of people had mobile. There was mobile ownership in Kenya of up to 94%, and 61% had smartphones. So this is what we can use. And currently there are also these mobile medical apps which can help in patient monitoring, empowering patients to monitor their own symptoms as well. There is one for palliative care, it's called PalCare, which can help patients to assess their own symptoms. So these are which patients can be trained on, and they can be used, and it also makes it easier for us as a provider to review and to monitor our patients. And we still need more and more research in telehealth focusing on implementation and outcomes. Thank you. I'll stop there.
Thank you so much, Dr. Elias. Please accept my profuse apologies for not getting your bio right. Thank you for the topic today on palliative care and its importance and the project that you're doing, and for sharing the impact it has had. I would like to introduce our next speaker, Dr. Kelvin Muridhi, who is a radiologist at Sonar Imaging Center. Dr. Kevin, you're welcome.
If you could put up the slides. So I'm Muridhi Kelvin. I'm a radiologist at Sonar Imaging Center today. All right. So I work at Sonar Imaging Center. We have centers in Nairobi, Meru, and Kakamega. And when talking about imaging of pelvic tumors, we know that imaging is a significant cost component of cancer care. Patients are sent for initial staging and multiple times for restaging. And especially when it involves multimodality imaging, for example, with pelvic tumors, cervical cancers, the cost can rapidly build up. And this is where it gets interesting, because you find patients are sent for staging of cervical cancer, and they sent for an MRI of the pelvis and a CT, an X-ray of the chest, which we know is inadequate for staging. And when oncologists look at this patient and think they cannot afford it, or patients go ahead and choose which imaging they're going to do, it complicates cancer care and delays treatment, especially when you don't have complete staging. And so, what are the imaging recommendations for pelvic tumors? For local regional staging, for majority of the tumors, MRI of the pelvis is the most appropriate imaging modality. For distant metastatic screening, CTs of the chest and the abdomen are used, or FDG PET. Now, for hepatic metastasis, MRI beats CT and PET in terms of sensitivity and specificity. And so when you look at a patient with, for example, a biopsy-confirmed endometrial cancer, you'd have to send them for an MRI of the pelvis and a CT of the chest of the abdomen, or a PET CT. And the cost, we look at the cost of that. And if you have indeterminate lesions in the liver, you end up requiring an MRI of the liver to be able to problem solve for you. So this is just to demonstrate how important MRI is for the pelvis. So this was an elderly patient with an uterine mass, and initially they were sent for CT, which is what you see on your right. And the green arrow shows you the tumor, but you cannot really tell the extent in terms of infiltration of the myometrium, extension beyond the serosa, infiltration of adjacent structures. And on the MRI, which is on the left, you're able to see the tumor there with the green arrow. You can see it's infiltrating the myometrium, extending beyond the serosa, infiltrating adjacent structures. And interestingly, the white arrow shows you a metastatic lesion in the iliac, in the sacrum on the left, which you can't really pick out on CT. the same patient had, you saw fluid in the endometrium on the previous image, and you see it here. But you're not sure, is it a cystic component? Is it hydrometra? And in this case, the CT cannot really tell you whether there is infiltration of the cervix. MRI does that for you. That's a diffusion-weighted image on the left, and that shows you proper infiltration of the cervix, causing stenosis, and so you have hydrometra, so it's not really a cystic component of the tumor. MRI is indispensable for imaging of pelvic tumors. In terms of examining the liver, MRI is more sensitive, mainly because you have multiple tools available to you. There's diffusion-weighted imaging, there's chemical shift imaging. You can null fat, null water, and be able to tell what lesions you're looking at. So this was an example of a patient with a pelvic mass, and on CT you could not identify any lesions on the liver, but on diffusion-weighted imaging, which are the images on the bottom row, you're able to see those metastatic lesions lighting up. And this is just to demonstrate the utility of MRI in assessing for hepatic metastasis. So the cost implications when you're imaging these pelvic tumors, those are the average costs. So if you were to send a patient for an MRI of the pelvis, the average cost would be about 25,000. CT of the chest and abdomen, 28,000. PET, about 70,000. And if you were to try and problem solve for the liver, if there are any lesions, you'd have to pay an average of 20,000 Kenyan shillings. And the cost would go up if you were to use liver-specific contrast agents. So you wonder, is there no way of reducing the cost of imaging for these patients? Could you provide a package that allows them to get completely staged without having to pick and choose what modality they're going to use? So you can see there's no role for a chest X-ray here for looking for lung metastasis. But we see a lot of patients sent for that simply because they cannot afford it. So what are we trying to put together? Staging package for pelvic tumors that incorporates all the modalities that you'd require. This would include an MRI of the pelvis, where you do all sequences plus contrast, an MRI of the abdomen, which would allow you to adequately stage the liver, and that includes diffusion-weighted imaging and dynamic liver sequences post-contrast, and then a CT of the chest, of course, with and without contrast. And the key thing about this, you do require real-time review of the images by a radiologist during imaging, so that you're able to determine whether to include dynamic liver sequences for the abdomen, whether to give contrast or not, and whether you need any other correlation imaging. What would be the cost of this? The cost of such a package would be in the range of about 45,000 Kenyan shillings for complete staging. The current cost, if you were to do optimal imaging, would be about 58,000 Kenyan shillings. The value proposition here is complete and optimal staging while saving time for your patient and reducing the cost. Of course, this would work for cash-paying patients. Insurance companies are yet to approve this. With the advent of SHIFSHA, it would be an uphill task trying to get this approved, but we will try. And this would only apply to biopsy-confirmed pelvic cancers. And we hope this would be able to improve cancer care by reducing the cost of imaging, especially for pelvic tumors, and save time for the patients. So we'll be coming up with more for other cancers, but for pelvic tumors, this is what we've come up with, and we hope it will be of value. So those will be my references, and thank you.
Thank you so much, Dr. Kelvin Muridhi. Indeed, we are sending our patients for CT scans, but apart from the cost implication, most of the facilities in the rural areas have a Tesla 0.3, where we can hardly see anything. We look forward to your reactions at the end of the session. Kindly allow me to introduce our next speaker, the very esteemed Professor Paul Odula, who is the current president of the Surgical Society of Kenya. Prof. Odula, you're welcome. A round of applause, please.
Good morning. Great. Thank you very much for the invite. My name is Professor Paul Odula. I stand here as President of the Surgical Society of Kenya. I'll give a brief presentation regarding what SSK is doing currently. That is a retreat which was held here about a month ago at the Grand Royal Swiss. I don't know if you can Grand Royal Swiss or Swiss Royal. But anyway, so it composed of my team, editor-in-chief, treasurer, secretary-general, everybody is there. It looks like it was quite an exciting time, and I did not be back here within a month, but here we are. So who does SSK represent? It's a professional society comprised of all surgeons and surgeons in training in the Republic of Kenya. This includes consultants, surgical residents, as well as medical students. How do we do it? We skillfully use our hands without causing further harm, stopping leakages, restoring continuity of tubes, reconstructing patchy disrupted tissue planes, removing dangerous tissues and foreign bodies. Our vision to be the premier professional society matters surgical health in our country, better outcomes through enhanced welfare and education of surgeons. That's an executive council made up of a president, vice president, secretary, vice secretary, treasurer. The other members include 2 consecutive country representatives, residents, medical students, Kenya Association of Women Surgeons, and co-opted members. In this case, we managed to co-opt the chair of the scientific committee. Those are the previous presidents. Of note, right from the beginning, the founders, including Professor Mulimba, who is an orthopedic surgeon. The other members of the founders are Professor Tinga, another orthopedic. The other members include Dr. Gynecologist, Awori, orthopedic surgeon, Tumba, plus I'm just highlighting some of the specialists who are part and parcel of the Surgical Society of Kenya. So previously, before we had this specialist, there was a so-called general surgeon, actually surgeon in general. Are you all aware about this individual? Maybe some time ago, those of you who are here more than 3 decades ago, used to do everything. I mean, everything. Used to do cesarean sections, myomectomy, drill bar holes, open prostatectomy, and this surgeon still exists till today in the rural setup. Are we together? He still exists, he's still there. They still do tonsillectomies. Some even do cataract surgery, cleft lip, and they give anesthesia using ketamine. They are there, and they are doing a lot of work. The new upcoming specialists currently are oncoplastic breast surgeons. I think Miriam Mutebi is here somewhere. She's the chairman of the standing committee in SSK for oncology. We have endocrine surgeons. Right now, I can't say there are many, maybe 1 or 2. Oncoplastic, we're less than 10. Colorectal, I think there's 1 now officially who's declared himself after training for an extra 2 years. Vascular surgeons, about 4 or 5. Transplant, another 5. HPB, 6, 7. Fetal surgery, 0. Why am I saying all this? In this country, we have about 11 surgical specialists doing all kinds of things all over the body, from gynecology, ENT, etc. And these ones are coming up. In the West, they're already there. In Kenya, there are very few. But we still have the general surgeon doing virtually everything. They're still involved in every aspect, be it trauma, obs-gyn, oncology. General surgeon is still there. And then the specialists will still do the oncology in the different specialty areas. Maybe this is my personal opinion, but I request the oncologists here to forget the idea of surgical oncology. There's no such thing as a surgical oncologist. Each specialty has got their own oncologist who's working at that. So when you make comments like, let all the stakeholders concerning oncology meet and remove the word surgical, I get a bit concerned. All right? We are part and parcel of making sure that oncology outcomes are good, it's cost effective, and you have fantastic outcomes. We proceed. So, my discussion today was supposed, what are the innovations in surgical care delivery that we are seeing? What is the SSK-driven initiative? Our initiative is mainly through advocacy, education, and training. By that I mean, we are participating in activities to increase networks, collaborations through standing committees. These are standing committees in SSK ever since its inception, and forums. We have partnerships, forging with these partnerships with like-minded individuals, groups, associations. We are now even involving government, not just MOH, but also the county governments. This is something recent and is beginning to bear fruits. The use of cutting-edge operating tools is a big part of this initiative. Then there's something else we're now doing, spearheading the digital community of practice, which I'll talk a bit more about. We heard about telehealth. I'll bring in new words like telepresence, telesurgery, and tele-whatever. We'll continue on with that. Last but not least, we, of course, always like to appreciate not just our members, but partner support, as I've seen in Kesho. So this is just a slide to show you the various committees that we have. Like the scientific committee, a long-time surgeons used to say, oh, SSK is there just for this one event. Sorry. SSK, there's always activities happening every year. Fine, the scientific committee may work the whole year in preparation for that event. But we also have other committees doing things. CMEs, we have research and outcomes, surgical outcomes committees, surgical training education, oncology, which is led by Miriam Mutebi. I deliberately put her in charge of that committee because she was actively involved with Kesha, and she's the current president of Aortic, and I believe most of you think surgical oncology is just breast. I'm sure you're all aware there's other aspects which you also need to consider. There's trauma. The gentleman there called Dr. Karuri, I'll talk a bit about him later. We do ATLS trainings, usually bi-monthly. Surgical camps are big activity in our calendar. Annals of Surgery, this is a local journal domiciled in SSK, and the editor-in-chief is an orthopedic surgeon. Welfare is a key plank of our activities. Global Surgery, the chair of this committee is a neurosurgeon, Professor Beverly Chesarem. I think you all know her. She's the chair of that committee. And we also have other forums. Forum for medical students. We actually have a students' surgical forum. I think we're probably the only association which does this, where all the medical students who are interested in surgery actually elect and join this forum, elect a president. The president of this surgical students forum is part of my council. So we have an incubator within SSK to try and gradually encourage these guys to do surgery by participating in our activities. Somehow we hope at least 20-30% eventually do surgery. Of course, we also have the Residence Specialty Forum and the Kenya Association of Women's Surgical Forum, which is again led by Professor Beverly Chesarem. This was a pre-conference workshop, basic laparoscopic surgery we did at the coast. It was well attended, not just by residents, but surgeons in training. We had our first vascular workshop training. It was in such demand that we had to reduce the numbers. We thought we'd do an annual training, but it looks like we may have to do biannual. Seated over there at the faculty. And there's a lot of interest in vascular surgery. I think back in the training, maybe not so much emphasis was put on that, but it's something ongoing, and we want to popularize this kind of training. KICC is one of the biggest providers of surgery or surgeons in our continent. In Kenya, it's soon overtaking MMed. Why? For many reasons. This kind of training avoids brain drain. This kind of training gets buy-in from the leadership. so that the surgeon continues on working in his county while training at the same time. So we end up getting more surgeons being churned out compared to the MED. And now MED has become expensive. Very unfortunate, but let's see what we can do about it. This graduation was quite exciting that we had over 40 graduates. So the bulk of the graduates in KICC at that time in Addis actually were from Kenya. Just to show you who the various chairs of committees are, that's Mutebi and Cheserem. And of course, I saw Boris somewhere here. This was a very exciting conference. 12 counties are represented here attending this partnership between SSK, Roche, AKUH, and National Cancer Control Program. And they were there to see and learn how best to manage breast cancer so that you have better outcomes, not just at the main hospitals in Nairobi and Mombasa, but all counties. This was another workshop I attended in Cape Town, again, innovations in global surgery, very critical in trying to transform the minds of surgeons. You know, surgeons tend to focus just on the OR. You want to tell them, look, it's not just operating theater, but there are many things which happen before which can be reduced or prevented before you reach the OR. So that's a big plank and a major committee in surgery. Another successful graduation of ATLS. This was a record, 400 surgeries in 5 days in one hospital at Makueni. It was exciting in that, and also insightful. The leadership was shocked to see that goiter is actually a problem in the county. They didn't know that. They might see a goiter in a month or two. Suddenly they saw 40 goiters appearing from the blue. So it helps to advocate clients to come early, not to shun hospitals and get it sorted out early. Then you can get early diagnosis, is it cancer or not, and start managing it before it reaches huge sizes. Welfare is also a major compact of our place. These two young surgeons, senior but young and in the peak of their careers, we lost them last year, and we invited their families for a cup of tea and gave a token of appreciation from the members. The Incubator Surgical Students Forum, they had their first scientific conference last year. I'm busy working and helping them to make sure the second one this year is more scientific, because it takes time before you get people sending abstracts at that level. But it's exciting that they're really keen on learning from the members how to improve on their skills. We've also introduced something new where all the medical students can apply to SSK. Whenever they're having a finalist dinner, we're willing to support and give a token award to the top student in surgery. So some of the medical students who may not be aware and are in this forum, please get in touch with the Secretariat and we'll facilitate that. Resident Surgical Specialties Forum. We actually have a residence forum. It just hit me that actually it's not just for SSK, but literally all the surgical specialties attend this as part of their bonding and learning from each other. Partnerships. Partnership is a big thing in SSK, especially during my tenure. We have met and engaged key policymakers. I mentioned in passing that we also involved in actually finally coming up with the first national surgical strategic plan and guidelines. We've had crazy situations where you go to a county and they have no clue how to set up a theater, an OR, or how to prepare processes. So we want to make sure there's something in MOH so that when SHA looks for background information, there's somewhere where they can reach out. And when Treasury asks what surgery is, there is something to read from. So we're all on the same page. We also met the Council of Governors, and they're all ready to buy in and work with SSK. All the surgical camps are always started off with a conversation with the governor and the leadership before we start involving or including the other stakeholders. This is part of the team we first met at Machakos. Later we met at Naivasha, and now we're busy trying to fine-tune these two documents. We're also in the process of not just signing MOUs, but also applying for research grants. And we have succeeded. So far, I think we've managed to get over 150,000 worth of USD grants, not just in helping doing research through SSK, but also sponsoring people to do masters. It's something exciting, and we're willing to venture into that. And I think it's something which we should use as a platform to push surgical health to another level. These are just some of the people we've worked with. Rotary Club is a key partner in surgical camps, And they've really helped sort out some of the logistics and fundraising for our surgical camps. The guy on the right, mark that face, his nickname is Blade Doc. He's called Dr. David Karuri. Maybe some of you have heard of him. He discovered, he's one of these surgeons who drive the real bikes. You guys know the real bikes? Are you with me? Yeah, he drives those things. And he realized that Boda actually transact business worth 1 billion Kenya shillings per day. 1 billion. That sector is just roaming around transacting this money, and it seems as if they're not well regulated. So he's decided to target that sector by trying to introduce various activities. These are the guys who are the first people who will appear when there's an accident. And these are the guys, when you drop off on your matatu somewhere, they're the last mile that will drop you at your doorstep. Why can't we use these guys, teach them first aid, try to regulate that industry so they can be more useful and helpful in trying to solve our health problems and bring sanity on our roads. Lifebox, another NGO which is very keen about clean-cut surgery, trying to popularize the use of WHO surgical checklist. Recently, we had an MOU with the Tanzanian Surgeons Association. They expressed a lot of excitement when they saw what we're doing. They say they want us to share knowledge and information on how to improve activities. And for the first time, the surgeons came together, all the surgical specialties. In this picture, we have the chair of obs-gyn, pediatric surgery, orthopedics, ENT, plastics, oromaxillofacial, urology, neurosurgery. They're all there. And they say, let's speak with one voice and make sure the surgical health, the narrative, is not just discussed in our absence, but we have to be on the table. We're tired of always being in the menu, yet we're not there in making the menu. So this is something which is exciting, we're pursuing, and it's already bearing fruits. The surgical specialties are also working with us with Merrill, trying to improve on their skills. Recently, Lariox sponsored a number of us to go and do endoscopy in India, and also China. Ahua, so we pronounce that. How can you have when you have two words following each other like A-O, I don't know how you pronounce that, Ahua, in China are helping us improve on the training of various highly skilled techniques in ERCP, ECD, and POM. These are very demanding technical skills which we're now using to try to improve on the skills of the surgeon in our country so we can do things better, have better outcomes, and improve capacity. Cutting edge tools, I mentioned this in the conversations with the stakeholder, the CS. Surgery takes a huge chunk of cost for the patient, be it cancer, whatever, you name it. Surgery is a huge component. But unlike 30 years ago, when the fee was limited to the surgeon and the operating theater, we now have a lot of other equipment and devices which are already part and parcel of that surgical bill. So the key thing is, how can we incorporate this and make it cost-effective without necessarily pointing fingers at the surgeon all the time and saying, you're charging too much money? The surgeon is also training. He's also trying to improve on his skills. He's trying to be better. There's a whole big picture we should not overlook. For example, the use of laser, harmonic, ligature, which has made thyroidectomy, which would take you 3-4 hours, now you can do it in an hour. So we have improved on surgical outcomes by cutting down on time. Endoluminal devices, minimally invasive, gasless. We now have gasless laparoscopy, where if you run out of gas, you can continue doing your laparoscopy. We have surgeon-powered laparoscopic equipment. Now we're going into telesurgery. This is laser surgery we're doing at the coast of the camp. We train people on laser surgery also in Karen recently. 10 surgeons left there calling themselves laser proctologists. Digital community of practice is the last thing I want to talk about, or second last thing. This is something which is new, where we have telepresence. I can be here and communicate with the surgeon in another theater, another place, and discussing what they're doing and getting feedback real time. This was when it was launched in Nairobi Surgical Skills Center. At the recent conference, we were actually doing telesurgery by watching surgery from Coast General and from India. And we did it the other way around. Recently, we had a conference in London watching what we're doing in Nairobi. This was the Future Surgery Conference where we were doing live transabdominal mesh repair at a hospital in Nairobi. And there we were giving step-by-step details of what we're doing and discussing on how we're doing. I think this is a major first and something that should be happening more often. We're talking about telepresence, building a digital community of practice. So far we've built that. We hope within a year we'll have to contact the whole of Africa and the whole world. Telesurgery, once we have the robotics in place, we'll be doing a lot of telesurgery, I'm sure within the next 1 or 2 years. We'd like also to appreciate our partners, our members. Recently, this was a graduation dinner where I was invited to give a speech. These are the ladies surgeons. Some of them are residents. They don't only wear scrubs, as you can see that. Pretty colorful, isn't it? President's Awards dinner, we had that recently where we awarded various awards to people for education, SSF member, Innovator of the Year. Dan Moengo always made sure things worked in the surgical camp despite the challenges. Mentor of the Year went to Caesar Bita, I think as a lecturer in the Masen or somewhere here, and also the treasurer of SSK. Associate Member of the Year, active hands-on, this surgeon from Kitale, Godric Onyango. Chapter of the Year was Coast, Committee of the Year was a camp, and this was the Surgeon of the Year, Edwin Mogere, a very nice fellow, and he's a real workhorse. Can work from 7 to 7 without getting tired. The sponsors, we always acknowledge the sponsors at our conferences. There's a shopping list. Secretariat, the executive officer is on the left. Glenn Mark, thank you very much for sorting me out to come and give this presentation. Thank you very much for listening. Asante.
Thank you so much, Prof. As a proud member of the Rotary Club of Malindi, I'm glad we've been in partnership with you. Just allow me, as a messenger, whose message has arrived telepathically, I believe the surgical oncologists would like to have a debate on what was projected here as the messenger. All right. I'm glad now to introduce our next speaker, Dr. Edwin Walong, who is a pathologist at the University of Nairobi, and he will discuss causes of death in oncology patients, a pathologist's perspective. You're welcome, Dr. Walong.
Right, thanks. Unfortunately, I did move to Maseno, so I'm local here. But thank you.
I'm sorry.
No, we understand when you see me, you see University of Nairobi, so I'm proud of that as well. Anyway, today I'll talk about autopsy. Right, I'm trying to see how to move this. And the reason we're discussing autopsy is to look at the local context of cancer deaths. And I will rely on two broad areas. I'll talk about the work that we do here in Kisumu and Siaya through the CHAMPS project, and a series of perioperative deaths that we see it. So what do we have here in Kisumu and Siaya? I know many of you are familiar with the CHAMPS study. So it's a child health mortality program surveillance and prevention, where we perform minimally invasive autopsies in cases that all deaths that occur in the community and in facilities in 2 sub-counties. You can see that's a sub-county where Barack Obama comes from. It's called Karemo, up north, slightly up north in Siaya. And the number of households you can see there, population of about 200,000, and there's an urban cohort here, an urban HDSS, where I think it's a neighboring HDSS to this facility. Now, how do we do these minimally invasive autopsies? You can see my colleague, Dr. Asike. There's Priyanka. I hope Priyanka is somewhere here. They were assisting me in the minimally invasive autopsy, where we just use needle core biopsies to sample target tissues. Now, what do we do once we have those? Of course, we recruit all deaths. We have a 80% consent and procedure rate. We perform minimally invasive sampling, tissue sampling, perform lots of diagnostic testing. so that we have a laboratory-informed cause of death. And then we sit together, similar to what you do in tumor boards, but this time we do this for all mortalities, infectious disease, and so on, and discuss what are the causes. Right, so, right. Now, once we have this, we have to assign a cause of death, and you're familiar with this form, and I hope nobody ever writes cardiorespiratory arrest. Please never write that. And what we want is a specific disease process, and it has to be filled appropriately in this form, which I know has been the subject of lots of discussions. Now, let's look at cancer. So, in this, I know there's a misnomer. You're wondering why we are talking about child health mortality, and I'm talking about adults. So, as part of, during COVID, we decided to also recruit adult mortalities and identify what causes of death are there. So we've already performed 300 adult meets. These are persons aged 18 and above. 87% of them we've sat down and decided what the cause of death is. 22% of all these have had a cancer diagnosis. And of these, 9 are males, 11 are females, and they're equally distributed. The cases that we see, you can see the cancer type. Most important cancer type in this region is HIV-related Kaposi sarcoma, and then, of course, cervical cancer, esophageal, breast, and colorectal in females, and in males, again, HIV-related Kaposi sarcoma, and we are increasingly seeing hepatocellular carcinomas, either associated with alcohol use or hepatitis B virus infection. Now, if you look at the causes of death, what did these people die of? I know some of you will say that they had cancer, they died with cancer or of cancer. So definitely some of them did die of cancer. If you look at the male HIV-associated Kaposi sarcoma, this was disseminated. We had disseminated hepatocellular carcinoma and various other diseases. But then again, of course, there are infectious diseases that occur in this population. Chronic kidney disease, sepsis, and the like. The ages at death, this being a small series, you can see that most of these individuals were young, a median age of about 44 years. And these deaths, especially HIV-related deaths and cervical cancer, were in individuals in their 40s, some in their 30s. And esophageal cancer, we saw it in individuals in their 80s. One of them is in their 80s, and of course, breast. But there was one interesting case where we had a 34-year-old, no, a 40-year-old with esophageal carcinoma. We had a 40-year-old. So we have unusual clusters of deaths among young people with cancer. And of course, these are the areas. And now, these individuals, what was the diagnosis at treatment? Or the diagnosis. So how did we get this information? From what we call the verbal autopsy. So verbal autopsy, I know many of you in public health like the verbal autopsy tool. It computes and gives a cause of death. But we realize that because for us we are using a laboratory-informed cause of death determination, we prefer to work through the narratives. And from the narratives, we tend to see certain descriptions. For example, the HIV-associated Kaposi sarcoma were treated as TB because of cough. And some of them had developed, they tended to move a lot because from this region, for some reason, everyone goes to Eldoret. So Eldoret, you seem to be doing something nice. And of course, KNH as well. So there's a lot of movement. So a lot of these individuals, what we are seeing with the CHAMP study is that local access to care, there's a problem. A lot of these malignancies, we all know that they're preventable. And infectious disease comorbidities definitely are common. Now let's look at a case series. I'm glad the surgeons are here. The case series that I selected here are mainly from complete diagnostic autopsy. The difference between the minimally invasive and complete diagnostic autopsy is that the complete diagnostic autopsy, we perform the full dissection, eviscerate, examine each tissue one by one, take lots and lots of tissues for evaluation. So we do have, we had clusters of sudden and unexpected deaths, and many of these appear to be thrombotic events occurring in the postoperative period. So what is the bias? So this is a lady who had a stage 2 ovarian cancer with total excision, resection, and had surgery postoperatively. And then the second surgery performed, and internal iliacs are ligated. So you can see she has surgery, then she has a bleeding episode. But now what leads to her death? In this histologic image, I'm usually used to a high resolution screen, sorry. But at least you can see somewhere in the center there that there are some blood, there are some thrombi. You can see the fibrin thrombi within the branches of the pulmonary artery right there. So definitely a diagnosis of pulmonary thromboembolism with marked vascular congestion being the immediate cause of death. Yet the surgery has been particularly done well. So now the questions that I would like to raise in this, you can see that thrombus obstructing that entire branch of the pulmonary artery. So of course we are seeing what you all know, that of course thrombosis is an important comorbidity in cancer. But the interesting thing is that when we look at the mortalities, many of them are associated with a bleeding episode occurring prior to this thrombotic episode. The bleeding is usually postoperative, usually. So now the challenge I would like to give you and my colleagues who are in hemostasis and the like, how can we manage this? How can we arrest this? And as oncologists, could you be a little bit more involved in the postoperative care of the post-surgical patient? And anyway, so that's the final cause of death. As I mentioned, we don't write cardiorespiratory arrest ever. And you can see we use the rubric where the immediate cause of death is the disease process with the shortest duration prior to death. And of course, and Prof. Odula is here, the surgical procedure will always be a diagnosis on its own right and has to be included in the diagnostic formulation. There's a second case here. This is a recent case of an individual with a T2N1 esophageal carcinoma that's distal, an eventful surgery but had an active chest drain. And because of that, the opinion was that there was a contraindication for anticoagulation. And this is the resection. No, this is actually the anastomosis. I don't know if this pointer is going to work, but you can see that there's a distended gallbladder to the right, and just above the pancreas, what you're seeing projecting upwards there in this photograph is a pancreas, and just above it is a constriction where this anastomosis of the stomach had been mobilized into the thoracic cavity. So what we are seeing is you can see that there is some sort of a cholestasis, that the gallbladder is enlarged here. This is the lung, and we see that the right lung, you can see that there are marked lacerations and hemorrhages. So why is this so? So the surgical approach was from the right. It was a subcostal thoracotomy from the right, and then the anastomosis was performed by a supraumbilical midline incision. And the surgeon, as he was, I think, accessing the esophagus, you can see the amount of injury to the right lung over here. So it means that this lung was in the way, and there are approaches in anesthesia where you can get this lung out of the way through a double barrel or a double lumen thoracotomy. I mean, laryngo, what do you call it? You know those things. So that you only ventilate one lung, collapse this other lung, and allow for proper access to the mediastinum. In addition to that, we see that there's a massive saddle embolus right there. So again, a pulmonary embolism. So how does this happen? You find that there's hemorrhage, and the hemorrhage is surgical. Because of the hemorrhage, then there's reticence in the use of anticoagulation, and eventually you have a thrombotic event. And the thrombotic event arises from the venous plexus around the anastomosis in the distal esophagus and distal stomach because of that anastomosis. Anyway, so it's a long course of death here, and as again I mentioned, we have to mention the surgical procedure if it's a direct cause of death and through the causal pathway, as you can see there. Anyway, I will stop here. So what we are seeing as an emerging challenge is that we may need you as oncologists to be a lot more involved in the postoperative care, particularly looking at thrombotic risks. in the post-surgical patients who are undergoing therapeutic resections? And again, how do you combine proper anticoagulation in an individual with a hemorrhagic risk? Right, so I'm going to stop here. So this was made possible by work that's done by many people. And here are some of my colleagues from the CHAMPS project visiting Bagathi Hospital, hoping to set up a project there. Maybe one day we'll move to Nairobi from this hub of research that Kisumu is. Thank you.
Thank you very much, sir, for your very wonderful presentation. At the end of this, we are going to call all our presenters back to the podium to ask questions. So I will be introducing our last speaker, but not the least. He needs no introduction. We all know him, Dr. Abeid. He is the KICC and is part of the reasons why I am here and all of us are here. So please, we'll have Dr. Abeid on the podium right now. And we are pressed for time. I think your time starts now. 2 seconds.
Thank you, Dr. Abiola, for the kind introduction. I would like to begin by thanking the scientific committee for giving me an opportunity, besides being the chair of this conference. Thank you, scientific committee. Today I'm going to present on oncofertility, a topic close to my heart, where we're going to discuss the issues of pregnancy after breast cancer diagnosis. My disclosure, I'm the scientific chair. So I'll start by giving a scenario. A 25-year-old, recently married, then she noticed that she has a breast cancer lump on her right breast. After noticing the right lump on the breast, this woman was started on cancer treatment. Unfortunately, the good thing, the mass disappeared completely on the right breast, so the patient thought there's no need for further treatment after chemotherapy. Only to come back later with another lump on the same breast, but this time she was pregnant at 18 weeks. At this particular moment, the patient was advised to abort and to remove the pregnancy, so she complied and she aborted. She started treatment, got only another 2 cycles of chemotherapy. Again, she disappeared. Then this woman, only to come back later after 1 year with another pregnancy, this time at 8 weeks. So these are the situations we are facing now in our clinics. Breast cancer is the most commonly diagnosed cancer in Africa. In the US and Europe, we see that breast cancer occurring in women less than 40 years old, what we commonly refer to as breast cancer in young women, is just 5%. But in Africa and other low and middle income countries, breast cancer in young women is up to 25%. Here in Kenya, according to various retrospective data, we see that is up to 25%. At my institution is 18%. We know that recently there has been a delay in most women having their first child, and more women are going to be diagnosed with breast cancer before completing their family. At the same time, we know that the use of chemotherapy can lead to premature ovarian failure. The woman will become menopause before her time. And there's a prolonged use of endocrine therapy, which again can impact the ability or the possibility for this woman to become pregnant. At the same time, breast cancer diagnosis and treatment, especially surgery and radiotherapy, can impact a woman's ability to breastfeed. So these are the pertinent issues which we are supposed to discuss today. Yes, I can see like the audience reacting to this. So this is exactly what I wanted you to see. We can see all of us, we are happy when we see a woman is pregnant. It means she's going to bring somebody in future. And here you can see a very beautiful young one. And this is a dream, I believe, for every woman and man if they have a family. We know that the incidence of breast cancer survivors, they are increasing in number, and the likelihood of a woman to become pregnant. Breast cancer is number 2. It means more women in breast cancer, they are going to become pregnant after the diagnosis of breast cancer. Over here, we are seeing the graph, the increase of survivorship. At the bottom, those are the women who were diagnosed less than 50 years. The amount of survivors, they are increasing rapidly. So with this increase, it means more women who are young, they are going to be diagnosed with breast cancer. As I had mentioned that the use of chemotherapy induces premature ovarian failure, and this will depend on the chemotherapy regimen you are using, the number of cycles, and the age of diagnosis. We know that all women, they have their ovarian reserve. The older you are diagnosed with breast cancer, nearly approaching 35 and above, the ovarian reserve is less. That means the probability for you to undergo ovarian failure is very high compared to a woman who was diagnosed at the age of less than 35. So these are key issues which we need to consider. With the use of the modern therapy, we know they also have an impact in ovarian failure. Now we have like data supporting immunotherapy in the preclinical. We have many clinical trials ongoing. The PARP inhibitors also, they are being seen like they are going to have an impact in premature ovarian failure. Being BRCA positive itself, it's predisposed to a woman having low ovarian reserve, a mechanism which we don't really understand, because when they were looking at the anti-Mullerian hormone in these women in BRCA positive, it was much lower compared to non-BRCA positive patients. Because of this, the ESMO guidelines, they have stated that it's compulsory for all women of reproductive age, they should undergo fertility counseling before starting any form of treatment. This one should be started at the diagnosis. So the method which we can use for fertility preservations are embryo oocyte cryopreservation of ovarian tissue. We can also use temporary ovarian suppression with GnRH during chemotherapy. The last method is not the preferred option, but however, in most low and middle income countries, the embryo cryopreservation and the oocyte and cryopreservation, they are not readily available, so we might be forced to use the last method. To look at the efficacy of using a GnRH antagonist during chemotherapy, we can see that on the bar chart, the patients who were using GnRH antagonists, they had lesser incidence of premature ovarian failure. And on your right-hand side, you can see the pregnancy rate was much higher in the women who are using GnRH antagonists. So this could be an alternative in our community, since other methods, they are not readily available. Now we need to ask ourselves, what is the best timing for these women that can become pregnant? The initial data was showing us that the best timing is after 5 years. However, now we are having much data, especially coming from the positive trial, considering a minimum of 2 years is also acceptable. But we know that most of these women, especially those endocrine receptor positive, they're going to be using endocrine therapy. So we need to stop this endocrine therapy at least by 3 months to ensure a washout of tamoxifen before the patient can become pregnant. If your patient is using trastuzumab, you have to stop for 7 months before the woman can become pregnant. With chemotherapy, it's preferable 12 months because of the ovarian failure, which can be induced. We cannot be very certain, like this patient, that can be able to become pregnant. So now I'm going to talk about the positive trial. So the positive trial, initially before coming to positive trial, Dr. Ann Partridge and her team, she set a questionnaire asking women globally if they are willing to become pregnant. Most of the young women, most of them, they had like no children or one child. They said they are willing to participate in the trial. To the record, the positive trial, the recruitment was supposed to be 5 years, but the trial was completed recruitment in less than 1 year, showing that more women, they are now interested in becoming pregnant. So they wanted all these women to become pregnant, but the total time, from the time you stop your endocrine therapy, remember these are estrogen receptor positive patients, so they were on endocrine therapies. From the time the endocrine therapy is stopped until when you become pregnant, and after you resume, you breastfeed and everything, should be maximum of 2 years, nothing was allowed. So here we are going to discuss the lesson from the positive trial. From the positive trial, the data which was presented in ESMO and San Antonio showed that it is very safe for patients who are ER positive to stop endocrine therapy to become pregnant. In last San Antonio, they also presented that ovarian stimulation is safe. Also, assisted reproductive technologies for women who are not able to become pregnant naturally. The assisted reproductive technology was very safe and more women became pregnant in that case. And then we presented in the last ESMO, like breastfeeding, that it is very safe after breast cancer diagnosis. And they were comparing the women who underwent mastectomies and the patients who underwent BCS. Even among the patients who underwent breast conservative surgery and the breast was radiated, still most of the women, they were able to use that breast to breastfeed, showing that the breastfeeding cannot be hindered by radiotherapy. So my take-home message is there's an increase in breast cancer survivorship, which will lead to more women becoming pregnant after breast cancer diagnosis. Oncofertility counseling should be done to all women of reproductive age. Pregnancy after breast cancer is safe and positive. Trial data is more reassuring. Breastfeeding after breast cancer diagnosis is safe and should be encouraged to all women who have given birth. This is my institution where I work at the Kenyatta University Teaching Referral Hospital. And finally, I would like to thank all of you for coming here, joining us the 3 days of this conference. And there's this study we are conducting with Professor Nazik Hamad. We are looking at the geriatric oncology practice. So I would like to request you to bring out your phones to scan this QR code to help us to answer this question, to understand what are the practice of geriatric oncology in Africa. Thank you so much.
So I would like to invite all our presenters back to the podium to quickly answer a quick question for us, please. Thank you. So this was a wonderful talk and a very, very wonderful lineup of presenters. So I only see... Right. So as our presenters are coming on to the podium to take questions and comments, if you have any question and comment, please, there's a microphone over there for you to ask your questions and comment. So as a vice president of the Aortic North American region, we actually do have this meeting every month. First Tuesdays of every month, and we've specifically picked that time slot because of Kesho. So I hope that you'll be able to attend and our next session. And pretty much one of the reasons why we have this session is that in the North American region, each month is being the presentation is by institution. So the first time we had it, we had AMPATH and Indiana University. The second time was month was Cornell, and then the next month is going to be Dana-Farber. So thank you again, presenters, for this wonderful talk and presentation. I know our time is well spent, so we're going to have the first question. Thank you.
Okay. Okay, good morning. My name is Dr. Mongare. I'm a clinical oncologist. And my question is to Professor Udula. He did a presentation on what his society is doing. So as radiation oncologists, we are usually at the very cutting edge of technology, combining art and science to push the envelope as far as it can go, using evidence-based medicine where possible and ethically, of course. So I was wondering, do we have super specialties anywhere already who use AI in advancement of breast surgery and the implications for breast reconstructions yet anywhere? Because I feel we can't be in harmony with the surgical oncologist in whatever tumor site as we push the AI agenda in radiation oncology, because that is the future. Thank you.
All right, thank you very much. I must reiterate that I seriously do believe in what you're talking about. Technology and is where we're going right now. I talked about telesurgery, and AI is part and parcel of what you're talking about. Not just from diagnosis, but also pathing, navigating in surgery. So we actually use AI in training. We can actually train a surgeon to see where he's going and give him a thumbs up whether he's in the right direction or not. But also in planning all kinds of treatment, definitely AI is a way to go. And we are looking at it, and definitely something we're willing to have a conversation on. Thank you.
Thank you very much. So we have Prof. Okay.
I'm still a teacher. So, Professor Paul Odula, thank you very much. Thank you all for your good talk, but the one that caught my eye or my ears was that of Professor Odula. Now, from the surgical side, we know very well that in cancer treatment, really the biggest modalities of cancer treatment is surgery and radiation. That one there's no question about. But when you are talking about curing cancer, of course, those two alone may not necessarily add on to the cures. So you need the other one, and that is systemic treatments of all types. Now, and we know that treating cancer today, an MDT is extremely important, very important. My experience from my part of the world is that getting a surgeon to attend the MDT attended by other people is extremely difficult. They shy away from MDTs, and there are some who attend, but the majority will, actually the majority don't even know that MDTs are important. They will ignore them, and the adding to the outcomes of treatment, like in breast cancer, and that is where you need neoadjuvant treatment. A lot of surgeons are ignorant of that. Let me use that word. They don't even know that it does exist. Adjuvant treatment, they also are not aware. A good percentage, in fact, there's only a small percentage of surgeons that know that these modalities are important. And then that rush to operate, to go and find out that it's inoperable, that is the rush. Even if you have good imaging that will tell you that you cannot take this patient to theater. That is an area that worries me. The other area, of course, that worries me is the surgical costs. You can't run away from it. And they tell you they are charging their skills. So I usually ask them, if your skills make you not human, then why did you learn the skills? Because there are some charges that don't make sense. They are actually inhuman. So those are areas that I take on with surgeons all the time when we meet with them. And of course, as you rightly said, I personally said at the National Cancer Control Program, the last document, that the idea of surgical oncology, I hope Miriam is here, Mitebi is behind me, because a neurosurgeon will treat cancers in the brain, and a hepatobiliary surgeon will treat cancers in that area. So the question of surgical oncology for me, again, has always been very nebulous. Thank you.
Thank you, Prof. Your concerns are very valid. Is it working? Yeah. Like we said, maybe let me start with answering the other one. In every village, there's always a madman. So there'll always be people who try and justify their costs depending on how they spent on their training. So for example, you get a surgeon who spent his own money traveling all over, improving on his skills, and when he comes back, he's being told, why should I pay you more than this guy who's been around whose outcomes are worse off than yours? So you try to justify, but there's also a reasonable limit you can justify. And that's why I try to encourage institutions, like Kenyatta, for example, KUTRH, actually actively are involved in the training of their surgeons. When you let a private surgeon or a surgeon take up his own training, then he feels he needs to sort out what he spent on his training. But that's besides the point. I agree, charges need to be reasonable. And number two, we also need to remember that you said something about 1% of surgeons, only 1% know about neoadjuvant. I disagree with you there. We have, I think it's bigger than that. probably I'd put 67% of the surgeons who are the young ones are aware about neoadjuvant and adjuvant. But the question is, how many chemotherapy places are there in these counties? How many? Can I go to Garissa now and say there's an oncology center where they're giving chemo? Yes. Good. Can I go to Wajir? Good. Now when you have those there, the next issue comes costs. You understand? The surgeon there is a COSEXA trained. He's seeing this breast thing coming through, and then he's doing told, before I operate on you, you must first go do an MRI, go do a CT scan, give neoadjuvant, and this cancer is growing. It's a serious problem, and we're doing a study on that. Even in Kenyatta, I have students I'm supervising to find the cost of doing breast cancer management. There are women who come and be told, oh, this swelling, you need to do CT scan and blah, and the woman hopelessly disappears for 8 months, looking for money to stage the disease. By the time she comes back, which is in stage 4. So it's back to what you're saying, costs. We need to manage the cost of diagnostics also, neoadjuvant, and it's not only the surgeon who's we're talking about here. The whole spectrum needs to be involved in bringing this cost down. Thank you.
Okay.
So, Professor Fana.
Yeah, so it's almost along the same lines. I know the surgeons are still fighting with us about chemotherapy and all of that, but I think one day we'll get there. I'll ask Abid. I realize that my patients, when I ask them about fertility options, they come back after 2 months to say, I can't afford it. So I think we have to come up with a framework, to triage our patients, because there are delays trying to get them to store their ovaries, and it's very expensive. I just like them to mentally think that they tried and it didn't work out. So we tried using Zoladex when the data came out that it works. The data now comes out that it doesn't work. Do you have any other options for your patient? Is it covered under insurance? That's number one. Let me ask the second question before. The second question was the gentleman who presented on the staging for gynecological cancers. But what if we find out that it's an early cancer? Do you really need to do PET scan, MRI, and all of that in the interest of choosing wisely? So I think sometimes just because we have the modalities doesn't mean that we should use it for all patients. We think it's free, but even it costs the system some money. So I don't know if he's answering first.
Thank you, Dr. Vena, for that important question. For me, all my patients, especially who are of reproductive age, I usually do counseling for fertility. I go ahead to discuss with them in terms of financial implications. I give them the options all available, including the Zoladex, which is the generic antagonist, which I was talking about. Then if they cannot afford, then we start the chemotherapy, and we hope they are not going to go into premature ovarian failure. The advantage in Kenya we have, Zoladex is fully reimbursed by our health system. So for our women, they are not suffering at the moment. So all of them, anyone who is interested in fertility preservation, we give the Zoladex, and it's going to be reimbursed, and they start on time. Because now with the SHA activation, once we do a request today, by tomorrow they're starting their treatment immediately, compared to how we were using the NHIF, they have to wait for a week. So now it's even much faster. You activate it today, by tomorrow the patient is already starting treatment. Thank you.
So in the interest of time, we can only take one more question. I'm so sorry. So please.
Sorry, can I respond?
My question goes to...
sorry. So there's a response to... I'm sorry. Yeah, please respond.
So you said, sorry, if I got you right, you said if you find out what, you don't have to... If it's early, so you determine it's early clinically or radiologically? Clinically. Okay. I still think you need to do imaging. So, for example, cervical cancer, if you do your clinical staging and find it's, there's no parametrial extension maybe, I think you still need to do the MR for proper local staging. And most of the times if you send them to Dr. Njoki, she'll ask for CT of the chest and abdomen for complete metastatic staging. I think it's just the standard of care that you need to do complete staging for your patients.
All right, so our last question, yes.
Yes, thank you, Dr. Abed, for oncofertility, something that we've been struggling with from the side of breast cancer. And I have a question. What mode of delivery would you advise, vagina or CS? And who should be involved in the care since conception of these people? Any hospital that they follow, any specialist that they need? You've talked about ER positive. What about HER2 and TNBC, cancer survivors that find themselves pregnant? And also the breastfeeding part. Most of us were told know how not to get pregnant, so we are not using contraceptives. And most of the cases that I've seen from my friends, they are advised not to breastfeed. Thank you.
Thank you, Lucy, for your question. So for all young women who have reproductive age must be on contraceptive on all period of treatment, because we don't want any unplanned pregnancy. Because remember, breast cancer is not like the end of your life. You need to enjoy your life and have your sexual desires and everything fulfilled. So we're not stopping them from doing that. We encourage using contraceptive, preferable the non-hormonal IUDs. These are the most common we encourage the women to use. Concerning HER2 and the triple negative, this one is less worrying to us, mainly because we know that after 1 year of adjuvant treatment, this patient is not having any other treatment. Comparing to the endocrine therapy, sometimes they have to extend all the way to 10 years. That's why my talk was emphasizing on endocrine receptor positive breast cancer because of the long treatment duration. Thank you for your question.
Okay, so one last question, I guess. I know this is a very hot topic. Everybody wants to ask a lot of questions. We are about 45 minutes beyond our time. More questions or not? Huh? So I'm asking oh my God, okay. Just one last question, and then we have to roll this out.
Thank you. So my question is to Dr. Abed concerning oncofertility. For these hormonal positive women who just finished radical treatment, would you advise them, or is it advisable that they start on hormonal therapy first for probably a minimum period of time before they conceive, or they can conceive immediately after systemic therapy?
Just clarification, in my talk I said the preferred period is 5 years. That means after the systemic therapy, the patient must be put on endocrine therapy. But now we are having strong evidence coming out. Even after 2 years of endocrine therapy, these women can become pregnant, and it's quite safe.
They just need to know that the data is not completely premature. So that's something they need to think about, but it's possible. And they should be adherent. They should be really taking their tamoxifen, on time and everything before they can consider to get pregnant, according to the positive trial.
For the fact that we have that amount of women being young when they are diagnosed with breast cancer, I think this should be our strength in Africa, and I think that we have to start thinking about endo-oncology department being integrated in our network from the beginning, so as to shorten the delay that we see with preservation and what have you. So thank you so very much for our speakers that have joined us here today, and for the listeners. This should be an ongoing conversation, and myself, Abiola Ibrahim, and my co-moderator, Michelle, thank you so much, and have a good morning.
We'll take a group photo to all the speakers here. Then after that, we have a request from Prof. Mansour, who has to catch his flight. So instead of going for tea break, we'll have his presentation, then we'll proceed for the tea break. Thank you. Yeah, let's step down. Stand up there. No, it's okay. Come down, come down.
So what I was saying, they're taking like 10 questions.
It's my great honor to introduce Professor Mansour Saleh, who is the head of Oncology Department at Aga Khan University, Nairobi. Professor Mansour today is going to talk to us about the application of the distress assessment and response tool that, in cancer patient, the Aga Khan University Hospital, Nairobi experienced. This was a phase 1 trial.
Thank you very much for allowing me to talk just before the tea break. The Kenyan tea breaks are rather long. I'm afraid that I would lose my flight if I did that, so thank you. What I want to talk about is establishing a psychosocial oncology program at AKU. Oh, there we are, thank you. It is called DART. DART is Distress Assessment and Response Tool, and this is the experience at AKU for the past 1 year. So DART was developed at Princess Margaret Cancer Center nearly about a decade ago. It was basically looking at the distress assessment and depression assessment in all cancer patients. The validation tool at DART resulted in an AI model whereby the patient would come in, answer a few questions, the nurse would assess, answer a few questions, and the AI model would pop out to say, is the patient depressed? Do they need counseling? Is the patient suicidal, needs to be admitted? Or the patient just needs a pat on the back to say things are going well. That AI model currently is being used at Princess Margaret. It has not been validated in Africa. It has been validated in China, in Qatar. So we attempted to validate it here in Kenya on our patients at AKU. It utilizes basically the ESA-SR assessment tool, which is looking at depression, looks at GAD-7, that looks at anxiety. We have the PHQ-9, which look at psychosocial well-being, and the Canadian score to say that how well the patient is doing. All these four are validated, and every patient goes through them. We have a psychologist trained in DART assessment, and we have a psychological assessment on top of these four particular tools. So just to give you a very quick upshot, we have nearly 400 patients being assessed, about 100 from hematology, nearly 300 from oncology, and about 25 from radiation oncology. We're just starting our process in RT. We look at the depression level, we look at the anxiety level, and the clinical assessment in the middle to say that does the validated score in a way match with what the psychologist is saying. So if you look at the depression level, 20% of our patients are depressed when they present with cancer. Of those who are depressed, nearly 35% have anxiety, which is the first column. And the anxiety level correlates very well with the clinical assessment by the psychologist. If you look at the right side, you have approximately 20% of patients have anxiety. Of those who have anxiety, nearly a third of them also have depression, and that is correlated very well with the clinical assessment of approximately 26% of patients having anxiety. So the conclusion overall for this rapid talk is that clinical assessment aligns with PHQ-8 or PHQ-9 and GAD-7 in a majority of our patients. The depression rates are comparable across the score for both radiation oncology patients, hematology patients, as well as oncology patients. And overall, depression is much more prevalent than anxiety in those patients who have studied. We have broken down patients who have been newly diagnosed as opposed to patients who have been diagnosed for a long time and see there's quite a difference. Early patients are very anxious because of a new diagnosis. Late patients are very depressed because of the discomfort, the stigma, as well as the impact of cancer on their care. Overall, this tells us that we would like to really include psychosocial oncology in the assessment of our patients. If a third of our patients are depressed or anxious, we clearly need to provide holistic care. The last point I would like to make is all of us feel like we have some intuition as an oncologist to be able to assess depression or anxiety. I can tell you that having assessed the 400 patients, 30% of these patients, when they meet with a DART counselor, cry, are weeping, are very distressed. Things that I do not see in my clinical practice when I see the patients. They tell me they're feeling very well, but when they talk to the DART counselor, they clearly have a sign of depression or anxiety. So my recommendation is that if this tool is successful at AKU, we should have it Kenya-wide to be able to see whether we can validate this Princess Margaret score in Canada, here in Kenya, and to see that the psychosocial assessment of our patients also included as part of their oncology care. Thank you very much.
Thank you very much. I think most of you must be surprised why the prof was talking so fast. So his talk was part of the rapid fire abstract. So this is how it's going to be when we come back after our tea break. I'll take one question, then we proceed with the tea break. Prof, I think your presentation was well understood. People, they understand there's a distress and depression among the cancer patient. I hope after this we are going to roll out in the whole Kenya so we can have an extensive data. Thank you so much. We wish you a safe flight. Thank you. So at this moment, I would like to thank everyone for coming for this morning session. We are going to proceed for tea break. Please let us make it very short. If possible, within 10 to 15 minutes, let us be back in this hall. We continue with our rapid fire. They are going to be very fire, very hot, and very rapid. Please don't be late. Thank you.
In Kisumu Pacho from November 20. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pacho. Welcome to Kenya International Cancer Conference here in Kisumu Pacho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pacho. Welcome to Kenya International Cancer Conference here in Kisumu Pacho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pacho. Welcome to Kenya International Cancer Conference here in Kisumu Pacho from November 21st to 23rd, 2024. The aim is to boost boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pasho. Warwaku Udala. Welcome to Kenya International Cancer Conference here in Kisumu Pasho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pasho. Warwaku Udala. Welcome to Kenya International Cancer Conference here in Kisumu Pasho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pasho. Warwaku Udala. Welcome to Kenya International Cancer Conference here in Kisumu Pasho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pasho. Warwaku Udala. Welcome to Kenya International Cancer Conference here in Kisumu Pasho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pasho. Warwaku Udala. Welcome to Kenya International Cancer Conference here in Kisumu Pasho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pasho. Warwaku Udala. Welcome to Kenya International Cancer Conference here in Kisumu, Pacho, from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu, Pacho. Warwakungala. Welcome to Kenya International Cancer Conference here in Kisumu, Pacho, from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu, Pacho. Warwakungala. Welcome to Kenya International Cancer Conference here in Kisumu, Pacho, from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu, Pacho. Warwakungala. Welcome to Kenya International Cancer Conference here in Kisumu, Pacho, from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu, Pacho. Warwakungala. Welcome to Kenya International Cancer Conference here in Kisumu, Pacho, from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu, Pacho. Warwakungala. Welcome to Kenya International Cancer Conference here in Kisumu, Pacho, from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pasho. Warwakugala. Welcome to Kenya International Cancer Conference here in Kisumu Pasho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pasho. Warwakugala. Welcome to Kenya International Cancer Conference here in Kisumu Pasho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pasho. Warwakugala. Welcome to Kenya International Cancer Conference here in Kisumu Pasho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pasho. Warwakugala. Welcome to Kenya International Cancer Conference here in Kisumu Pasho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pasho. Warwakugala. Welcome to Kenya International Cancer Conference here in Kisumu Pasho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pasho. Warwakugala. Welcome to Kenya International Cancer Conference here in Kisumu Pasho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pasho. Warwakudala. Welcome to Kenya International Cancer Conference here in Kisumu Pasho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pasho. Warwakudala. Welcome to Kenya International Cancer Conference here in Kisumu Pasho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pasho. Warwakudala. Welcome to Kenya International Cancer Conference here in Kisumu Pasho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pasho. Warwakudala. Welcome to Kenya International Cancer Conference here in Kisumu Pasho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pasho. Warwakudala. Welcome to Kenya International Cancer Conference here in Kisumu Pasho from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu Pasho. Warwakudala. Welcome to Kenya International Cancer Conference here in Kisumu, Pacho, from November 21st to 23rd, 2024. The aim is to boost medical tourism, healthcare infrastructure, and all other benefits of health in the community and Kisumu at large. From the fresh fish from Lake Victoria and a place where money is not a problem, but how we can spend it. Ladies and gentlemen, welcome to the 8th Kenya International Cancer Conference here in Kisumu, Pacho. Kisumu, Pacho, from November 21st to 23rd, 2024. The aim is what's large. From the gentlemen, welcome to the 8th.
Seed Boy, Manza Kamalion, King Esther, Yavsana, the boss lady. Atababandeli mokili 1000 fois, je te choisirai toujours à chaque fois. Ayebaki yokozala mama ya bana, motema nange betaki quand je t'ai vu. Afsana boss lady of Minama World. Seed Boy, tu connais ma faiblesse. Afsana, oyebi que na lela yo. King Eska, Seed Boy, je me battrai toujours pour toi. Malgré Manza Kamaliona, motema nanga ne anyo. Finisana gauche à droite, Afsana. Tikana memelo breakfast na mbeto. Afsana wewe ni malaika. Bébé t'es la meilleure maman. Mina kupenda sana Afsana. Je remercie le ciel. Merci Nzambe. Afsana nos bénédictions. King Eska, Seed Boy, je me battrai toujours pour toi. Malgré Manza Kamaliona, motema nanga ne anyo. Finisana gauche à droite, Afsana, Afsana. To the left, to the right, Afsana. Tushuke tupande. I love you, Afsana. I need you, Afsana. I love you, Seed Boy. I need you, Seed Boy. Où que j'aille, Afsana. Où que je sois, Afsana. Elle me fait vibrer, Afsana. Mama na banana, Seed Boy. Maya, Mina, Jibril, Mama, make me dance. Nicheze pole pole, Tokos, Afsana. Binizana pelebe, boss lady. Let's go. Let's go. Nicheze pole pole, mama. Binizana gauche à droite, Afsana. Wamba, Afsana. To the left, to the right, Afsana. Tushuke tupande. I love you, Afsana. I need you, Afsana. I love you, Seed Boy. I need you, Seed Boy. I love you, Afsana, mama. The boss lady. Ozamalaika, Nzambatingelanga. Nga, Seed Boy. I will die for you. Je pourrais mourir pour toi. Mina kupenda sana. Afsana, Afsana. Let's go. Camaleon King SK, Papa na Marcia SK, Léonie la Lionne d'or, Maman Léa Dabani.